So we've got some questions from people online that couldn't attend today, and we're going to weave those in with questions from the audience. So while you're thinking about what question you might like to ask, just be reminded that it needs to be a generic one as opposed to a personal one about your personal situation. So I'll start off, Dave, if that's okay.
So if you stick your hand up in the air if you've got a question.
And there's roving mics that will come and find you.
A roving mic will come and hunt you down.
Okay. So, briefly, how do you know when you've had a heart attack or a heart event?
So the main answer to that comes down to the diagnosis slide. So a lot of it is all about troponin.
Okay.
So if you go to hospital and you've had some chest pain and they measure your high sensitivity troponin and it is normal, that is not a SCAD event. We do see sometimes that you can get very nasty episodes of post-SCAD chest pain that can end with patients coming in hospital. It's very common, readmission to hospital, and often those episodes will be troponin negative. And sometimes even afterwards, it can, you can almost feel as if you've gone back a little bit and then you have to sort of build yourself back up. That's very common, and I sometimes sort of say, whilst the trajectory after SCAD is one of improvement over time in most people, it actually does this. So it's going up, but when you're on a down and it feels like you've got nasty chest pain and it feels as if you haven't made any progress, whereas actually you are making progress, it just takes that longer time frame, 18 months, sometimes a bit longer, for things to get better in most people. If you think about it, something like if you've broken your leg at the time you had your SCAD, how long would you expect to feel a little bit of niggly discomfort in your leg afterwards? Probably, it was a nasty break, maybe even a year or two before all of that achy goes away. Because the heart's on the inside, we sometimes think it should be better immediately. But actually, it does take a bit of time. It needs to do its healing as well. And so, those kind of symptoms are very common. They do get better, but they are a normal part of recovery after SCAD.
Okay. A quick question about insurance. It's asked an awful lot. So, is SCAD a disease? Do we have to tick the box? Do you have heart disease? And then another question is about, do you have to say that you've had a heart attack recently if you've just had one of these episodes of chest pain, going into hospital and coming out again and it wasn't? So
with insurance, the thing to remember most of all is that the purpose of insurance companies is to not pay out. That is what they're trying to do. They're trying to find a reason not to pay out. So when you're completing the insurance forms, it makes sense to err on the side of being overly, if you like, permissive in terms of the things that you are acknowledging, rather than under. Because what you don't want is to be in a situation where they go, but you have heart disease and you didn't tick the disease box, so we're not going to pay out. So generally speaking, heart disease, yes, SCAD is a heart disease. Heart attack, yes. SCAD, as I've said, causes a rise in troponin and essentially causes a heart attack. Even if it's tiny, even if the MRI scan afterwards is essentially normal, it's still a heart attack. There are insurers that will specifically recognise SCAD now, and that really helps because you're able to specifically define the condition that you have. What was the second part of that? I've forgotten.
If you've got sort of ongoing angina, do you have to declare that, or these extra chest pains?
So it's tricky, that one. So in terms of, if you have chest pain and you go to hospital and your troponin is negative, that is not a heart attack. So you don't need to say that every episode of chest pain that you have is a heart attack. That's not the case. It is harder because sometimes insurers will ask whether you still have chest pain. And that is a tricky one if you still have chest pain. And I think what you have to acknowledge is if that's the case, it's better to say that you still have chest pain if you do, because that makes sure that you're covered by the insurance policy that you're getting. Even though, if, for example, the question is, do you have angina? Actually, most post-SCAD chest pain is not angina. Angina being pain that you get during exercise. So when you go for a walk, walking 500 meters, you get 300 meters, your chest gets tighter and tighter and you have to stop. You stop, you rest, the chest pain goes away. You think, I'll have another go, you go another 500 meters, 300 meters, your chest pain comes on. So it's that predictable exertional element, not the thing that we often see in post-SCAD chest pain, which is you have a good day, you think, I'm going to take that dog for those all over the place that I usually used to take the dog before my SCAD. and then at the end of the day you get your post-SCAD chest pain afterwards. So it's tricky, but as I say, I would always err on the side of ticking yes, because it means you're covered, and that's what you want.
Okay. Now, I think there was a question in the audience. Yes?
Thanks so much for that talk. I learnt so much. Can you say something about pulsatile tinnitus and when that will go away?
Do you know what? I'm going to Bagsy that.
Yeah.
Because, Tina, are you all right to take that question as part of your talk, or do you want to answer it now, maybe? See.
Do you want me to stand?
Yeah.
So who asked the question? Was it down that side? So pulsatile tinnitus is like a whooshing sound near the ear. So like whoosh, whoosh, whoosh. Very, very troublesome. In itself, it doesn't mean that you've got a particularly serious issue with the blood vessel near the ear, but it is very troublesome. So it's very commonly described in patients with FMD, and it's also described in patients with SCAD. Some people with pulsatile tinnitus will have some narrowing or some ballooning or something with the blood vessels near the ear, but just the presence of it doesn't mean that it's more serious or it's more likely to cause a problem. It's more just that it's a distressing and can be quite annoying symptom. There is another support group called WHOOSHERS, so WHOOSHERS.com, and they've got a website that you can look at, and they talk a lot about different coping strategies, so CBT, various ways of dealing with it. And I suppose it's good to know there's a sense of community around this issue, that it is very common. Does that answer your question?
Okay. Can I just add another thing? So Tinnitus UK have just been talking about tinnitus and menopause, as if we haven't got enough to cope with getting tinnitus as well. And there is a rise in the number of people that experience tinnitus, not the whooshing one, but the general horrible thing I get, which is like noise all the time, and linked to menopause. And again, it's something that needs further research. They don't really know why that's happening, but just thought I'd add that in, because that's something fairly recent with Tinnitus UK. So the next question is about tortuous coronary arteries and turbulent flow.
Okay, so the tortuous coronary arteries is essentially where there's more curliness than we normally see. Increased tortuosity is something that is seen in SCAD patients. It's been described a little bit in one study from the Mayo Clinic, but it definitely occurs. Tortuosity is also associated with high blood pressure. It can happen when people get a bit older, so there are lots of reasons why you can get more tortuous blood vessels. I tend to not focus on it greatly, because ultimately, if you've got slightly more tortuous coronary arteries than the next person, there's not an awful lot you can do. You can't sort of mind your coronaries a bit straighter, and I can't really give you the straightening tablet. So, I probably wouldn't focus greatly on it. The most important thing is, I wouldn't worry about it greatly. It's more something for us clinicians when we're looking at the angiogram. If we see a lot of tortuosity, we need to think about whether that narrowing might be SCAD, because those two things sometimes go together. What was the other thing?
It was about the turbulent flow. So what does that mean in relation to your SCAD? And is it a suggested risk of coronary artery disease on top of your SCAD?
So coronary artery disease on top of SCAD is definitely, generally speaking, not something you need to worry greatly about. But the genes that we've identified in SCAD patients actually protect you a little bit from conventional coronary artery disease. So finding important conventional coronary artery disease in SCAD patients is more uncommon. Sometimes we find it, again, that might be the reason why one patient is on a statin and one patient isn't on a statin. In terms of turbulence and changes in blood flow and those sorts of things, these are things that are of research interest. It's one of the reasons why people think that controlling blood pressure and maybe use of beta blockers may affect how the blood flows through the artery, and that may be how it determines risk in SCAD patients. We don't completely understand these things yet. So well done whoever put the question for being ahead of us on the research. We'll try and catch up with your theory with some data as soon as we can.
Thank you. Just two questions really that kind of connect with each other. So I just wanted to find out, is more research being done to check the healing or healed process? Just because I feel like when we get put on medication, we just instantly want to come off, but obviously we have to wait for the healed process. And I know you talked earlier about not doing another invasive angiogram. Yeah. So is there sort of research happening to find out other ways to tell us that it's already healed?
Yeah, okay. So Some of this has already been done in terms of more historical studies where routine follow-up angiograms were done and essentially showed that the process had healed. What we have done is, and part of this is not research, it's actually just been clinical practice. And of course we learn as we look after patients to some extent. And when we started doing, looking after SCAD patients, for a period of time we did CT scans of the heart arteries routinely to follow patients up. And what we found was, first of all, again, they were pretty much invariably normal, that we would not see anything abnormal, but also that it was actually quite difficult to see the areas where the SCAD was. Because you remember at the very beginning I said that SCAD often affects that bit further down where the artery's a bit smaller and so on. And CT scans are not great at seeing that because of their spatial resolution, as I said a little bit earlier on. So I think we can be comfortable that for the overwhelming majority of SCADs that they heal by themselves. We tend to use CT scans for people that have SCADs that are more upstream, so up towards the beginning of the coronary arteries where the arteries are bigger. So I will still do CT scans in those patients just to check. But I have to tell you, it's incredibly uncommon for me to find that they haven't healed completely. Okay.
Thank you. And the second part to that was, once it's healed, why do we then need to keep taking medication?
Yeah, okay. So the coronary artery is the conduit. It's the thing that's taking blood to the heart muscle. But there can be problems with the heart muscle, because obviously the reason the heart attack itself is an injury to the heart muscle, and you get a little scar on the heart. So there are a number of reasons that tablets are still needed in some patients. First of all, it's the stents thing. You might need some tablets because of that if you happen to have stents. Secondly, it's the extent of that injury to the hearts. Many SCAD patients have small injuries. Some do have more injuries. And we have to think about those and make sure that we manage those with the right tablets. And then the third thing is just trying to make sure that we do the things that we can do to minimize the future risk of SCAD recurrence based on the information we have at the moment. And as I've said to you, that's mainly focused around blood pressure control and beta blockers where people are able to tolerate them. So those are really the reasons why. There are some SCAD patients who are managed without tablets, and they tend to be people that have had, some small injuries to the heart. Everything has settled back down afterwards, and some people that just, are unable to tolerate a beta blocker because they just feel very unwell. But one of the things that we do in the SCAD clinic is that individualization process, is to, think about you and your specific set of circumstances, and therefore try to work out what's the minimum amount of tablets. And we are trying to get them down to the minimum that we think is a good idea for you, and also to explain it to you, so that hopefully when you go away from the clinic, if you are still taking tablets afterwards, you have an understanding as to what they're there for. Because if you don't understand why you're taking the tablets, it's easy to forget them, isn't it?
Is there another question in the... Oh, yes, here we go.
Yeah, my name's Sandra. I'm actually involved in research. And one of the projects I'm involved in, and we're talking about heart attacks, so it will be coming out and people are more interested. And it's about the effects of medication, not just on your heart, but say kidney. So one of the projects is about heart failure and renal conditions. Now, we're looking at the SCAD and the arteries, but obviously some people will have an effect on the heart. Then their medications may then have an effect on their kidney. We're talking about mainly, we call them water tablets, but diuretics. So it might be a question that comes out in the future when people are seeing this research and see heart attack, renal, kidney failure. So it's really just about to say, do we as SCAD patients look at our renal conditions, but they'd be looking at it as the heart attack side. So it's really more of things are coming out in the big wide world about the effect of the heart disease on kidneys. So it's about preempting.
Yeah, okay. So bodies are whole things, aren't they? And that's the important thing to remember. We talked a little bit about sort of psychological side of SCAD, and hearts are connected to heads and hearts are connected to kidneys, of course, and that's a very very important and pertinent thing. I think for the SCAD population, distinct from some other populations, patients tend to be younger and tend not to have so much in the way of problems with other areas. It is something that gets thought about. So sometimes when you switch medications, some of you will have had this experience, if you switch medications from one thing to another, then we will say that you need to have your kidney function checked with the new tablets to make sure that your kidneys, for example, are managing that okay. So it is something that is borne in mind. I think ultimately the solution to all of those kind of questions is proper clinical trials, because proper clinical trials will, if you like, see what the benefits are, what the risks are, and then enable us to be able to come back to you and say, with solid data, absolute certainty, these are the things that we think you should be taking, and these are the reasons why.
So just to add to that, because this is something that's the bread and butter of my role. So the heart and the kidneys are like twins, and what benefits the one benefits the other. There is very, very bad press, the word nephrotoxin, which I absolutely hate and needs to be gotten rid of, and please can your research get rid of it? Because medications such as ACE inhibitors, angiotensin receptor blockers, SGLT inhibitors, the new eplerenone, finerenone medications are all phenomenally helpful for the kidneys, very helpful. Water tablets are very helpful. So the only time that you'll have a problem with water tablets is if you're over drying, so you're drying people out. Otherwise, you most definitely do need water tablets to try and get rid of salt, to try and get rid of excess water in the body. So if I can just give you courage that these medications are hugely helpful if you're in the group that needs them, benefits the heart, benefits the kidneys at the same time. So it's like double whammy benefit. Sorry, I had to say that. Couldn't resist.
I mean, I think it's important to say that in the SCAD population, that is a small group. So most people are not going to be in that group.
Hi. Yeah, you'd mentioned earlier that the CT scans don't have the best resolution. So if you're doing the head-to-hip scan, what is the best kind of thing to use? Okay,
so when I was talking earlier, I was talking more about coronary artery CT scans, so CT scans that are looking at the coronary arteries rather than that are looking at the arteries elsewhere in the body. And the question there was focused a little bit around, can you use CT scans of the coronary arteries to accurately diagnose SCAD? And the answer is, if you see it, you can, but you will miss some cases of SCAD where CT scans don't have the resolution to be able to spot it. And that's the reason why we're trying to develop new approaches that use slightly different parts of the CT image to be able to pick out those cases more accurately, so that hopefully in the future we can use a CT plus Phi and this other stuff to enable a non-invasive approach to diagnosing SCAD. Head-to-hip scans. So the head-to-hip scan is it's a screening test, and we're the screening to have a look and to see whether there are any other arterial abnormalities that we can find. We do find things, but it's relatively uncommon. In fact, it's really quite uncommon to find things that we need to do something about. And so we have to try and get a balance right between imaging strategies. So the most high-resolution imaging strategies, which are the invasive angiogram approach, so taking pictures from the inside, if you like, and there are some places in the world where they will do that after you've had your SCAD angiogram. They'll actually take the pictures of the arteries at the same time by taking pictures. Those have, if you like, the highest X-ray dose associated with them. So you will need the most X-rays to be able to take those pictures. CT scans, so a CT scan from the brain to the pelvis, again, is a very good way of looking at all those arteries, but does require an X-ray dose. That's not to say that it shouldn't be used, because we are, if you like, taking a decision that we want that information to be able to guide people's management and to be able to understand what's there and make judgments about tablets and whether we need to keep things under observation. So CT is the next, if you like, has the next highest spatial resolution. And then the next thing down is MRA, which is where you use MR scans to look at all of the arteries in the body. That has a slightly lower spatial resolution than CT scans, but doesn't require the use of X-rays. Now, because we know that finding things that need action taking is uncommon, and that the things that need action taking tend to be bigger, so larger aneurysms, for example. We have erred on the side of using MR scans in the UK to be able to screen for these things. In some places and patients, MR scans are not available, and so we use CT, which is a perfectly reasonable and internationally accepted alternative. Indeed, in the US, most patients are managed with CT scans. So hopefully that answers your question, which is that the spatial resolution of those imaging approaches is, in our view, adequate to provide the information that we need as to whether there is something there that we need to do something about or not. Does that make sense?
Yeah.
Yeah.
Hi, thanks. You said about SCAD classes as heart disease. If it's an isolated incident and it heals completely, why does it class as a disease rather than sort of a one-off event? Because that sort of tarnishes you for life almost, doesn't it?
I kind of agree with that, and I do get the fact that, you know, words make a difference. As well, we were talking a little bit about tears earlier, that tears are terrifying things, whereas bruises are rather less terrifying things. And it's actually just descriptions of the same thing. The reason for talking about the heart disease thing is because if that's what the insurance company puts on there and you tick no, then, you know, can your very expensive lawyer override their very expensive lawyer in persuading them that you do not have heart disease if you've had SCAD? And it's more that issue. I completely agree with you that if your SCAD has healed and the injury to your heart is small and you are doing really, really well on minimal or whatever medication, then, you know, I don't consider you in the same category as somebody who has other heart diseases, which mean that they, you know, can only walk 20 paces or something like that. Clearly, there is a whole spectrum of heart disease, but it's more about when you're, you know, it's very tempting when you're doing those insurance forms to go, no, I haven't got that, you know. But actually, you know, the reality of it is that when you're on the beach in Spain, you want to be there in the complete knowledge that you don't have to worry about whether somebody's going to, you know, not honour your insurance.
Thank you. There's a question at the back there, and I think there's a questioner down here. Quickly, while we're getting those to them, a question about dentists. Is it okay for SCAD patients to have dental local anaesthetic containing adrenaline? Yes or no? Yes.
No problem with that at all. You know, there's a little bit of a timing thing sometimes. So sometimes early after SCAD, and particularly if you have stents, you may be taking 2 of these antiplatelet drugs. You may be taking aspirin and something else, maybe clopidogrel or ticagrelor or one of these similar medications. And obviously what they are trying to do is, what those medications do is they prolong bleeding time. It means your blood takes longer to clot. So it makes sense if, for example, you often only need to take the clopidogrel for some months or the first year or something after your procedure. It makes sense if your teeth can wait to wait until you're not taking the second antiplatelet drug and are just on the aspirin. Or if there's a reasonably good chance that you'll be stopping the aspirin, it will make it easier for your dentist if you can wait until we're going to stop that. So there's some things there, but absolutely no problem. We do not want SCAD patients to end up with rotting teeth.
It's just a quick question. If you've been diagnosed with SCAD by a cardiologist who seems to have a good understanding of what it is, do you think it will be beneficial to be referred to a SCAD clinic as well, or do you think it's not necessary?
Gosh, that's $1 billion question, isn't it? In the SCAD, all I can really say is what I see. So in the SCAD clinic, around about 10%, probably something like that, of the patients that are referred to the SCAD service, we are not sure that they have SCAD. So that's an important starting point. You know, some of them will have conventional coronary artery disease, some of them will be, you know, and some people are, you know, we have to accept that there's uncertainty. And for those patients out there who are in that position, and there'll be 1 or 2 of them, I always say it's best to embrace the uncertainty, because if there is uncertainty, that's what you want people to know about. Because if you happen to have chest pain or something happens again, and usually that's very unlikely, as we've already said, but if it does happen again, it's much better that you go to the doctors and you say, well, I had something before, and ultimately we weren't absolutely sure what it was, and here's my letter from Dr. Adlam. Then it means that they then keep an open mind, Whereas if you go to a doctor and say, I had a SCAD before, they're going to go, oh, SCAD. And you're in that box, yeah? So, yes, so I think there is a sort of a diagnosis thing that we do. It isn't a one-size-fits-all. I'm aware that, my colleagues around the UK are brilliant on the whole, and, many of them will be doing a great job in the SCAD clinics.
Can I ask a quick question now from the bucket
the bucket.
while we're
Excellent.
sorting ourselves out? So, at migraines, one of them, is it safe to have Botox when you suffer from migraines if you've had a SCAD? Because Botox is becoming an increasing treatment for migraines. And then the other one is about a new migraine medication that is on the... I'm going to give it to you because I can't read it.
Yes, it's that stuff.
One, yeah.
Yes.
Rimegepant. What do you think about that one,
So,
please?
Migraine in SCAD is a tricky one. There's not a massive amount of data on what to use and what not to use. We do get a bit anxious about triptans. That's because we know that they are things that affect arteries and blood vessels and cause big changes. Having said that, there are some reports in the literature of SCAD occurring close to people using triptans, but lots of people use triptans, so it's quite tricky to be absolutely certain that there's a risk, but we think there may be. And so we try to not use triptans if we can. In terms of acute treatments, what we tend to suggest is using a combination of high-dose aspirin and paracetamol with an anti-sickness tablet at the earliest time that migraine symptoms begin as the first line. There are a number of things which can be used to prevent migraine. So I can't tell you how many people who come to clinic on their beta blocker who say that they haven't had a single migraine since they had their SCAD. And it's because those beta blockers are an effective migraine prophylaxis. They prevent migraines. And there are some other medications which do that, and there are some other medications which can be tried. In terms of Botox, the only things to think about with Botox are, again, those medications which make you more likely to bruise and bleed. So obviously aspirin to a small extent. If you're still taking 2 of those medications, that could be more of a problem. So, if you get Botox injections and end up with a big bruise, that might end up being more of a headache than the headache you were trying to prevent. In terms of other than that, outside that, I don't have a particular problem with Botox injections, certainly for this indication. And I know several of the SCAD patients who have difficult migraine have tried that option. There are a number of things for migraine. Sometimes we need to get some specialist advice as well for really tricky to manage migraine patients, which we do have some of as well, I'm afraid. Hopefully that answers that.
Thank you. This question here.
It's a little cheeky question, actually. Is there anything, regarding funding for future research, is there anything we as a patient group could do to maybe stalk the British Heart Foundation by bombarding them with emails?
I think my most important message is we are basically here, and I am able to present you a talk on the research in SCAD because of Beat SCAD. There's no doubt also because of the British Heart Foundation and their original support and because of the BRC, but Beat SCAD have been instrumental in allowing us to do what we do. We are really hopeful that having published a genetics paper in a journal that the British Heart Foundation would recognise as being a reasonably quality journal, that might turn their attention more in the direction of my applications than previously.
I was just going to add to that, Dave. It is actually worth this group here considering whether they might want to undertake a priority setting partnership in SCAD.
Yeah,
the rationale for that is that NIHR will fund research that has come up as a priority for patients. Now, we're running our digital health one on a shoestring, but the cost of running an entire priority setting partnership, if you economically cost it, is about £70,000.
Yeah, it's huge.
It's relatively expensive. However, if you've got a group of enthusiastic people who can do the work, it is possible to do it for considerably less. And so that's how we've managed to do ours, which is in digital health. But it might be something for us to consider going forward. And if this group thinks it's worthwhile pursuing, then pursuing something along those lines, because it will set us up. And again, British Heart Foundation cannot ignore a priority set by a PSP.
Okay. That's when you as a patient group decide what the research questions are. And so it's patient driven, and the NIHR and the Medical Research Council, they love that now, and so that would be a way forward. The James Lind Alliance is a very expensive way of doing it because they provide the people that help you do that. But I'm actually involved in another priority setting exercise right now, and that's being done just by the patients on a shoestring. So it can be done, and I do think that's something we should be considering, Dave.
Yeah.
Hi. So my questions are about the non-invasive diagnoses methods that you were talking about. How would you determine in practice which method to go down, the non-invasive or the angiogram, given that a lot of SCAD patients, myself included, present with no symptoms other than the high troponin?
So are you talking about at the time of an acute presentation? Yes, okay. So at the moment, the best diagnosis strategy is with the invasive angiogram. The reason for that is that it has a higher spatial resolution, which means you can see smaller things. And because SCAD affects further down the arteries, it affects often the smaller arteries, 2 millimeters, maybe even less in many patients. And invasive angiography can see those small arteries. The challenge with CT scans is that they're not so good at seeing that. So if you've got a SCAD that affects the upstream vessels, and that's more uncommon, it does happen, some of you will have had this, but it's more uncommon. So if it recognizes the SCAD, then it will be usually correct. So if it picks it up, it will be correct, but it will miss some. So when I'm talking about CT scans at the moment, it's not necessarily that it's all bad. CT scans can be used. So for example, you might use a CT scan in somebody that you're pretty sure has had SCAD, for example, somebody who's had one before, just in order to make sure that there's nothing in those big vessels that's serious that you might need to do something about, and just to make sure there isn't something else going on. So the fact that you then have a CT scan that's normal doesn't mean that you haven't had SCAD. It actually means that the CT scan, the SCAD that's there is in a blood vessel that's too small for the CT to see clearly. So at the beginning, at presentation, the invasive angiogram is definitely best. We are working on adding lots of beautiful bright colours to allow us potentially to be able to use CT in the future as a non-invasive tool that's good enough, but we're not there yet. So what we need to do is first of all develop the tool, which is where we're at the moment. Then once we have that tool, we need to then apply it in SCAD patients and demonstrate that it is as effective as an invasive angiogram. And then what we might do is, if you are, let's say, 3 weeks after delivery of a baby and you're having you've had a small heart attack and we think, that looks like SCAD to me, you might do the CT scan with the extra thing. And if it looks okay and it looks like it's SCAD, you might then not go down the line of the invasive angiogram with the associated risks and things. But that's, research vision rather than current reality. But that, this is what we want to be able to do. We want to be able to try and reduce the number of invasive procedures that people with SCAD require, if we can.
Well, the mic is coming to you. I've got a quick one here. You talked about collagen earlier. Are collagen supplements of any benefit to SCAD patients?
I'm all for things that make people feel better. So if it's something that you find helps you, great. Do I actually think that there is definitely something that it is doing that somehow taking a collagen supplement makes those arteries better or stronger? I don't think we have any evidence for that at the moment. So personally, I would invest all the money that you would spend in your collagen supplements, pop it in a jar and spend it on a really nice day out.
Can you hear me? Yeah, my question's about the research, and it's the importance of, this is what they all call me, dissemination and implementation. Because as we say, you write the research papers, and in the good old days, they went on a shelf and you got your name on a paper, but now it's it's like our responsibility as, SCAD survivors to make sure that this information gets out there, and then it's also that it's implemented. So, do you have any help of how we can help you to disseminate this? But again, like you say, most importantly, implement it and get it into policy, because that's the only way we'll ever make a difference.
Yes, so I think you make a very good point. it's something that we're very cognizant of. In terms of what we do in practice, we will tend to use the SCAD website and the SCAD YouTube channel to disseminate the findings that we make. The reason for that is that the SCAD website is excellent, and it allows us to be able to put little podcasts and little video descriptions when the latest research comes online on that system. The other thing is that, we, and it's not just we as in me, but it's as in my amazing team at SCAD, and also my other colleagues who are sitting in this area here, spend a lot of time and energy going out there and talking to people about the findings of the research and of what that means to their practice. So I think we have at least 2 regional cardiac rehab educational sessions that we will be going to in the next couple of months. There's another one, I think, from the Northeast that wants to have a talk going. So, there is always more to do. I'm very conscious, particularly of our first responder group, that I think you did some talking with ambulance crews and things back.
Yes, that's
before.
right. And Sarah does a lot of work with paramedics.
Exactly, yeah.
An awful lot
yeah.
of work.
So,
I think what I'm trying to say is that we are with lived experience. They often say the people with lived experience have got a strong voice independently, but a stronger voice together. And I think that's where I'm trying to say that, I'm sure everybody in this room would want to help and input and do whatever we can. It's just a matter of, well, just ask us, I think.
Well,
I think I speak on everyone's behalf. I hope we do anyway.
We will do. So thank you very much for that offer.
And of course, we use the SCAD stories in our promotional material and on our websites, and those stories, I know, have inspired our medics over here to get involved. So that's really good anyway.
And also things about experience of the SCAD clinic that people have written, posted on the SCAD website. When we've had, and some of you have been involved with our management days, so one of our challenges is, trying to get the NHS and the NHS services to accept that this is an important thing to do. We all think it's an important thing to do, but often if you're a manager and you're trying to run a hospital and you're trying to deal with hundreds of local patients and everybody's on strike and it's all a bit of a nightmare, then SCAD is low down on your priority list. And what some of you have been helping us with is really showcasing the clinic to everybody, from the chief executive to the cleaner, to say, this is why we do it, this is really important, and to try and get people behind it. And again, we're very grateful to those of you who have helped us with that.
And of course, when we were asking for volunteers earlier, that's not just about volunteers to fundraise and to do various things. It's also about writing your story, because it's good to have fresh material on the website so we get new stories. And also to go along with Sarah or myself if we're educating. So I do cardiac rehab, Sarah does paramedics, to tell your story, because we tell ours often enough, but it's good and it's nice to hear different stories as well. So there's that type of volunteering as well. So if there's no more questions, there's loads in the bucket. So there's been a couple of people who are asking about COVID and SCAD.
Yeah, okay. So let's start with COVID and SCAD and COVID vaccination and SCAD. The question is, or the first question I'm going to pose is there a link between the two? Now, if there was a link between COVID and COVID vaccination and SCAD, what I would see is I would see patients who have had their COVID or COVID vaccination at this time point, and then maybe 2 weeks later, maybe 3 weeks later, at a time when it was maximally causing a reaction in your body, maybe 2 days later, I'm not sure, then you would get your SCAD. So I would be seeing patients coming back to clinic within a few days or a few weeks of having a COVID vaccination or their COVID infection. It would happen in a predictable time frame. What I actually see in clinic is patients who had their SCAD an hour after their COVID vaccination, or a day, 2 days, a week, a month, 6 months. And it's probably also somebody who had it an hour before. But they don't say that. They don't say, just an hour before I was going to have my COVID vaccination. You'll never guess. I check. So what I'm seeing is a random distribution. And for that reason, I do not think that there is a link between COVID and COVID vaccination and SCAD. The next question is, should I have a COVID vaccination? Now, that depends a little bit on the precise government guidance as to who should and who shouldn't and who falls within the remit and so on. I'm not going to get into that. But as a broad principle, if you have the opportunity to have a COVID vaccination, indeed a flu vaccination or other vaccinations, generally speaking, the vaccination is better than the disease. So if you have a vaccination, you might get a sore arm, maybe a fever, feel a bit rubbish for a few days. The bad things with vaccination are very, very rare. We hear about them because they make for good press stuff, but they are very, very rare. Whereas COVID itself, you know, unfortunately my lovely secretary who would have wanted to be here today isn't here today because she's had COVID and she's poorly, you know, and it's a nasty thing to get and it can set you back, you know, for quite a stretch. So for me, if you get the chance, have the jab.
Thank you.
Hi, my question is, after a SCAD patient has recovered, what is the recommended best practice within A&E for a new and very different acute episode of chest pain? And I'm talking years rather than months. And this would be, usual checks are ECG and troponin are normal, but it's definitely a very different chest pain.
Yes, okay. So new things, not even necessarily just chest pain, right? I'll come to specifically to chest pain, but one of the challenges when you've had a significant illness is that when you get symptoms, it's a temptation to hang that on the thing that you had before. So you get something, maybe, I don't know, a bad headache or something. Does that relate to something that's related to the SCAD or, you know, so it is that thing. And the reason I say that it's important is that we have to keep an open mind about the fact that it's possible to get something else. God forbid, but it is possible that you can get something that's different. And so it is important to keep an open mind about these things. So in terms of the specific scenario that you talk about, clearly the starting point is the same three things that we said before, the history, the ECG and the troponin, or the high sensitivity troponin. But, you know, a big part of that is the first one, which is that really listen and have a think about what it might be. And then we have to make some decisions. And again, those will be individualized. So for example, a patient who's had previous stents or previous bypass grafts as a consequence of having SCAD, we might need to think again about those stents and bypass grafts if you've got chest pain. Even if the troponin is negative, there may be scans that we would need to do that. If we listen to the story and we think it sounds a bit more tummy-related stuff, and maybe you're on aspirin, which can sometimes cause a bit of irritation of the tummy, we might need to think about that. So it is really an individualized thing, but I think my message is that, you know, yes, the post-SCAD chest pain thing we recognize, but of course, it's not always the case that all symptoms relate to SCAD, and we just need to keep, as clinicians and clinical teams, but also as patients, just keep an open mind and make sure we're giving symptoms or things that are new in your body the right level of consideration, I suppose. Does that sort of answer your question? Yeah.
There's a couple other questions here in the bucket about chest pain, and bearing in mind that over 20 people in this room had their SCAD in the last year, so they're all very new. So the questions around chest pain are, what is the cause? Is it just healing, or is it something else? Is there anything that can be done about it, or should people just rest and, you know, take some paracetamol? And about the specific timing of chest pain linked with periods,
yeah.
And is there something that you
about
can
that? Okay,
say
so
about those things?
A whole lot of chest pain related things. Okay. So the first thing is, in terms of chest pain, we just have to, again, just listen to the story, make sure that it makes sense and it fits with what our experiences of post-SCAD chest pain. Of course, there may be very occasional patients who do have true angina. My experience is that those are sometimes the patients in which we've got the diagnosis wrong and we need to think again whether it's conventional coronary artery disease rather than SCAD. But that is just one thing that has to be considered. In terms of post-SCAD chest pain, we try not to medicalise it if we can. The reason for this is several-fold. First of all, we know that it tends to get better over time in most people. That's not everybody, but most people it tends to improve. Secondly, we know that the response to medication is quite varied. And so sometimes medications can have, angina-related medications can have very minimal impact on post-SCAD chest pain. We do have some medications which we try, which have been effective in some patients. I'm never absolutely certain whether it's the tablet that helps or the fact that it's taken me some months in order to try and find something that works, and actually maybe it was just the passage of time that's got the chest pain better rather than the new tablet. Difficult to know sometimes. But there are things that we can try. So there is a spectrum of post-SCAD chest pain for people who have very little to people for whom it is really debilitating. And we understand that, and there will be some of you who are at the end of the spectrum who have more severe symptoms that we will need to try some medications to see if we can make things better for you. So it's a range of things. So sometimes post-SCAD chest pain is cyclical. In patients who have that, again, it tends to improve over time, but sometimes that persists. And in some patients, we find that use of a hormonal strategy to essentially try and iron out those cycles can help. And so sometimes patients who've had, for example, a Mirena coil or another contraceptive strategy, because you're basically leveling off the cycles, it seems to improve the chest pain. So it's a strategy that we try sometimes in some people. It's not necessarily a panacea for all post-SCAD chest pain, but it's, again, it's one of those things that we're thinking about for patients who are having more troublesome symptoms or more persistent symptoms.
So I'm just wondering if there's anybody that has any questions for any of the other speakers that perhaps suddenly thinks of something. It'd be lovely to hear from you. And also from our wonderful health professionals, have any of you got any questions that you would like to ask? Yes, come on then, Anne.
It was just to add a point, there's quite a lot of confusion about the imaging and the use of CT. And one of the keys is that the CT and its resolution for all of your arteries in your head-to-tail scan is actually fantastic. Our problem with coronary arteries is that they move. Okay, so your heart arteries are in motion all the time. When you lie still, your heart arteries are still in motion. The rest of your arteries aren't. And so those little arteries, trying to keep them still, we have to lower your heart rate to get a really, really good look at them. And so that's why, because people say, well, if CT is good enough to look at everything else and the dissections that might be elsewhere, why is it not good enough to look at my heart arteries? And it's because they move all the time. So we're getting better, and the technology is getting better at that. It will come. I'm an imager, you can tell.
Yeah. And we need you.
So I have a question here, which is for you, Liz, about the exercise. Well, Dave as well, but it's about this avoiding the ones that are in the red. Avoid these exercises. Can you put that in the context of, the first 6 months, the first year, or when a bit longer in the tooth like us, and you get to 10 years post-SCAD?
So I could give you the very short answer, which is no. But the longer answer is that's what we hope to be able to answer for you. And that's why I strongly encourage you to keep in touch. There are a whole load of questions about how the coronary arteries behave in people with SCAD after exercise that we would love to answer. And Dave's got some very ambitious ideas about it. We've got some slightly less ambitious and slightly less invasive ideas about how to investigate it. One of the things we want to understand is what you were doing before your SCAD and what you're doing now. So please do contribute that data to us. But yes, we would really, really love to answer these questions. And that is something we can do with you. So I'm sorry that's not completely helpful. Dave, do you want to add anything else?
No, I think that with a lot of things with SCAD, a lot of the things I've talked about today, we would love to have more data, more trials, more information. And we have to make our judgments and give our advice based on what we have at the moment. And that applies to the exercise thing as well. So we would love to be able to say everything's fine. There are a few signals that say maybe we just need to think about things a little bit, and that's the basis for that advice at the moment, that there's a little bit of data that suggests that, humping the biggest weights maybe not, that more extremes of exercise maybe not. But we are actually probably more permissive in the UK than most of our international partners, who tend to be much more if you like, risk averse from the perspective of exercise. So it's worth bearing that in mind as well. But our perspective is exercise, good for the heart, good for the head, but maybe don't go completely crazy.
So of course, that really links to the whole thing about patient priority setting, because if as we as a group decided that out of all the questions we wanted answered, this was the one, then that makes a very strong argument for funding for Dave from the National Institute of Health Research or the Medical Research Council, or indeed for us to all get out there and ride our bikes gently, bake scones, which is what we used to do in the old days, wasn't it? Scones for SCAD. We might have to reinvent that one, I think.
I'm all for scones.
Raise the money ourselves to be able to fund more research. There is a couple of sort of campaigning questions that have come along, and one of them is about how we get SCAD added as a list of conditions on the NHS conditions website, because we looked at that years ago and tried very hard and were assured it would get there, and it's still not. It is in Wales, that's right, and it is in Scotland, but it's not in England and it's not in Northern Ireland, so it's...
Yeah, I mean, these things are, if you like, a bit of a work in progress. We are pleased to see SCAD starting to come into international guidelines as a specific entity. I think that's progress. We'd love to see it in specific things in the UK, like NICE recommendations and so on. But NICE are going to respond when we have clinical trials. Yes. So when we have clinical trial data, they will start to put things out that are more specific to this condition. So it's a bit of a kind of, it's one of those things we have to step up as well. And if we deliver the information and it's backed up by proper data, then they will start to pay attention because they will have to.
So this is a question from me, actually, which is about the hospital admissions and discharge information. That SCAD used to be lumped in with lots of other random heart issues, and it didn't have its own code. Mm-hmm. And that has recently changed, has it not? And have you now been able to access the data as to how many patients are getting coded as SCAD?
So no, and that's something that I think we can look at. I mean, one of the things that is important is not just that codes exist, but that the codes get used and that people are aware of those codes. Because I think that's something, again, we may need to, or we can think about having a little bit of a campaign to make sure that it's not necessarily the likes of me, but it's the people who are doing the coding. It's the coders that we need to make sure that they are aware of those things. So, yeah, more to be done, I agree.
Okay.
Sorry, just a quick random question. Things like giving blood and stuff like that. I just wanted to know, where, as a patient, we stand, just because I know that there's loads of tick boxes in terms of what we can't do.
So it's a good question. I'm not absolutely certain what those tick boxes are. They say no, do they?
Yeah, they say no.
So computer says no by the sounds of things. Sorry about that. Oh, okay. No. Okay.